So my task really is to present a synthesis of the work that particularly the biomedical working group within Strive has focused on, but also kind of with contributions from the other working groups around the thinking about how to accelerate HIV prevention and how to think about combining and integrating interventions. So what I'm going to do sort of over the next period of the talk is really talk about the challenge that we face with prevention currently, then share with you the 3 lessons that I think we've learned from Strive, and then try to bring it all together. So what is the issue? I think we would all agree that there remains an unmet need for HIV prevention, and that's both primary prevention as well as secondary prevention with treatment. And this unmet need is particularly amongst key populations, in part because of their behaviors, but also because of barriers to preventive services. And when Strive started, the discussion at the time had really focused on or been dominated by how to prevent HIV by changing individual behaviors. But there was a growing and emerging recognition that many of these behaviors are shaped by the social context in which people live, and that they may in fact be barriers to individual behavior change. And Strive was really established to kind of begin to think about how to respond against some of these upstream factors. Around the same time, we also saw a number of advances in the field of biomedical prevention, with trials reporting benefits for antiretroviral treatment in people living with HIV to prevent HIV transmission, as well as the first trials reporting the successes of pre-exposure prophylaxis. And so there was huge enthusiasm for how antiretroviral therapy might be able to really be a game changer in terms of HIV prevention. But I think what we know is that many of these, while these advances in biomedical prevention offer real promise, we absolutely need to take them to scale if we're going to see population level benefits. And this is again where, if some of the Strive thinking I hope to show you, will talk about how we think we can achieve that scale. So I'm pretty sure all of you who are at this conference recognize that this is a graphic of the treatment cascade. And the cascade has become very familiar in HIV. And the point of this cascade is really to explain the steps that are necessary to achieve viral suppression among people living with HIV. And that could have both individual level benefit, but also could have population level benefit in terms of reducing incidence. Targets have been set, and as you can see, we have counted the proportion of people living with HIV who are tested for HIV, initiated on treatment, and virally suppressed. These are the latest updates from UNAIDS, and I think you can see that there, while enormous progress has been made, there is still a ways to go really to achieve some of these targets. And later on in the talk, I'll talk a little bit about some of the barriers to achieving these targets that Strive has uncovered. So in 2017, UNAIDS highlighted this important prevention gap, that we were way off target for achieving the goal of reducing new infections to fewer than 500,000 globally by 2020. And that, kind of the efforts to date, really, we see that in terms of condom distribution, half of the requirements of condoms that are globally required have in fact been distributed, that we would need to double our male circumcision efforts to achieve our prevention targets, and that in terms of PrEP, a relatively new intervention, only about 5% of the coverage targets have been achieved to date. So we really need to think about how to begin to take prevention to scale, and to understand perhaps where some of the barriers to scaling up prevention are. So some groups have started to think in the same way as we have a treatment cascade, can we have a prevention cascade? And this is work that was part of a series produced with UNAIDS. This particular graphic is work done by Jeff Garnett and his group. And on the one panel, you see a client-centric approach to prevention, and on the other, an intervention-centric approach. But what is common to both approaches is this idea that there is a population that are at risk for HIV, of them a proportion recognize that they're at risk, And as a result of that, a proportion of them would take up prevention intervention and be able to use it effectively to achieve continued HIV protection. And with the intervention-centric approach, we really kind of think about access to services. So these cascades have begun to kind of generate interest. But as you can see, there's attrition at each step, and it's important for us to begin to understand what are the barriers to achieving prevention as well as treatment. So STRIVE generated 2 questions. The first was, how do structural factors act as barriers to ART-based prevention? And the second question that follows that is, can we programmatically address these structural factors in order to optimize the impact of ART-based prevention at a population level? And so now I'm going to take you through the first of the 3 learnings that have come out of STRIVE. And lesson 1 is essentially that biomedical tools are not going to be able to do it on their own. So there are 2 key ideas that I want to share with you that come from the work done by STRIVE investigators. The first is that based on the idea of the inverse equity hypothesis, this idea that new interventions are going to initially reach those of higher socioeconomic status and only later affect the poor. And this work has been applied to HIV, but was based really on observations by the epidemiologist Cesar Victoria when thinking about child mortality and morbidity. So STRIVE investigators applied it to thinking around HIV prevalence and did an analysis looking at data from 7 countries, looking at changes in HIV prevalence in young people, where changes in prevalence could be a measure of kind of new infection over time and with different levels of educational attainment. And this is data from Tanzania, but really suggests that in fact that is the case, that with time people of higher early on in the epidemic, people of higher socioeconomic status had higher rates of HIV infection, but with time we saw declines in those groups of higher socioeconomic status, whereas people of lower socioeconomic status were more likely then to be HIV infected. And this inverse equity hypothesis is not just important for thinking about prevalence of infection, but also thinking about programming. That when we think about programming, perhaps people who are going to have access to HIV prevention might be those of higher socioeconomic status, and in fact those who need it most may take some time to access those interventions. So the second thing that we considered really was, and you saw Mitzi present this conceptual framework earlier on, but this is the conceptual framework that really defined the thinking in STRIVE. And here it's applied really to notions of risk and how upstream factors could influence behaviors which subsequently lead to HIV transmission. But we also wanted to think about whether some of these upstream factors like gender or stigma or alcohol or lack of economic opportunity could also influence people's access to HIV testing or PrEP or ART initiation or retention in care. And so we looked at these 4 factors and we conducted a review of reviews really to map the existing evidence for the effects of gender inequality, poverty, stigma, and alcohol use as barriers to the treatment or prevention cascade. And what I'm going to share with you are findings from the review around gender inequality and poverty, but pretty much the results applied to all 4 of the factors that we reviewed. So first of all, when we looked at violence and harmful gender norms, what we observed is that gender inequality really undermines women's decision-making and autonomy about HIV testing. And often it's the fear of intimate partner violence, not even violence itself, that prevents women from accessing testing, although results there were variable, with some studies showing that this was the case, others showing no effect, and one suggesting, in fact, that women in partnerships where they'd experienced intimate partner violence might be more motivated to test. But also fear of violence prevented disclosure. When we looked at how violence and harmful gender norms might impact on ART initiation, what we saw is that IPV was associated with an inability to access care and treatment, and it was associated with lower current use amongst women. And when we looked particularly at work around PMTCT, we found that women were reluctant or in fact did not involve their partners in PMTCT services because of fear of violence. When we look then at viral load suppression, what we see is that women who experience intimate partner violence are less likely to adhere to their antiretrovirals, and that lower adherence also translates into poorer clinical outcomes. So poorer outcomes for CD4 count and viral load. And in other studies, intimate partner violence was associated with treatment discontinuation and loss to follow-up. So a very clear message that violence and harmful gender norms have an impact on the treatment cascade. And while there was limited data for prevention, we've started to see the same messages emerge around prevention. Bearing in mind the inverse equity hypothesis, we also explored socioeconomic status. We used a very broad definition, but we wanted to understand the impact of socioeconomic status, or kind of aspects of that, on access to the treatment and prevention cascade. And we see a similar pattern with reports of transport costs, distance to the health facility, food shortages, or patient-related time constraints related to employment are all barriers to testing and subsequent linkage to care. Also, unstable housing, another dimension of poor socioeconomic status, was associated with poor access to services. And these same factors have also been reported as barriers to ART initiation, and similarly also have been barriers to viral suppression. And importantly as well, we saw studies that also reported food insecurity as an important barrier to ART adherence. And in fact, interventions around provision of food were seen as supportive of continuing antiretroviral therapy. So the review really provided substantial evidence that these structural factors undermine the treatment cascade, with emerging evidence that they may undermine prevention, particularly PrEP. And kind of while there was some variability in the results, this was partly, we thought, due to the absence of data or to the fact that some definitions like socioeconomic status are quite difficult and kind of encompass a broad range of areas. So it has led us to the thinking that HIV prevention programs really are not going to be successful if we do not in some ways try to address these barriers to both the treatment or the prevention cascade, and that we need to recognize that beyond just structural factors having an impact on people's risk for HIV, they also are undermining the use of biomedical prevention technologies. And so the next step really for us as investigators is to identify evidence-based interventions that can address these structural factors and to begin to integrate them into HIV programming to see if we can modify then the kind of HIV prevention outcomes. So the logical next question is, well, is there evidence then for changing structural factors' influence within meaningful programmatic timeframes? And the lesson that we have learned and the evidence that we have reviewed or generated is essentially that structural factors can be addressed within program timeframes. And what I want to review now in this next session are several examples of work that Strive has done, looking at how you can modify violence and harmful gender norms, modify stigma, modify alcohol use and their effects, and how these successful interventions could influence our thinking around HIV programming. So the SASA trial was a trial aimed at a community mobilization approach to changing social norms that perpetuate violence against women and increase HIV. The program is a program that focuses really on community mobilization activities that are driven by activists, but encourage people to reflect on their relationships and power within relationships, and so encourage and support changes in behavior. And the program was evaluated in a cluster randomized trial in Uganda in 8 communities and had a number of very promising results over a 4-year time period. So importantly, SASA had significant community impacts on attitudes towards the acceptability of violence, but also actually reduced the occurrence of physical violence amongst those with a history of violence, and that was 52% lower, which is an impressive reduction. levels of sexual concurrency reported by men and women's reported ability to refuse sex were also altered, and this is important both for violence but also for HIV. There are also a number of promising impacts, and the one to highlight is really that overall levels of physical violence were lower, although that wasn't significant, and there was also evidence of new occurrence of violence in relationships being changed. Another interesting finding is that in some ways this intervention was like a vaccine. It had a herd effect, so you didn't need to be directly exposed to the intervention to achieve the benefits. And the cost was about $1 per day per activist supported. So another example, which also emanates from investigations by Strive investigators, was the IMAGE trial. It was also a cluster randomized trial, and it evaluated a combined microfinance with a participatory gender empowerment activity in South Africa. In IMAGE, what they saw were significant impacts on violence and HIV over a 2-year time frame, with more participants reporting reductions in intimate partner violence. The microfinance component saw benefits for households in terms of poverty, and there were also some upstream effects from an HIV prevention perspective around improved communication, but also higher uptake of testing in young women, and reported lower rates of unprotected sex in young women. Another important thing that the IMAGE trial showed us is, many people say, well, poverty is driving HIV, and if we get rid of poverty, we'll get rid of HIV. But I think the illustrations from IMAGE make an important point. This is a very busy slide, and it may seem confusing, but if you look on the first panel, microfinance versus control, this was really some analysis that was done after the trial, which were comparisons between people who had a microfinance intervention exposure only, but still part of the microfinance overall program run by the group that did the microfinance. Then comparisons between IMAGE and the control, and then IMAGE versus microfinance. And the bottom line of this slide is really that after 2 years, while both IMAGE and the microfinance groups had benefits in terms of economic improvements, if you look the rest of the way down the panel, and particularly on your, the last column, what you'll see is that IMAGE demonstrated consistent benefits across a range of other domains which were related to empowerment, intimate partner violence, and HIV risk behavior. So what we can see is that there are incremental benefits to combining interventions and to adding on interventions onto social protection or microfinance interventions. So now I want to change gear and talk a little bit about stigma. Stigma is important for HIV because it's a social process which really involves labeling people with a particular condition, identifying that group with negative connotations, and that leads to divisions where there are some us and them, and people who are in the other group often experience negative outcomes, including loss of social status. But what we've also seen is that those negative outcomes can also be associated with poor health outcomes, and can actually act as barriers to access to HIV testing, treatment, and continued access to services. So what can be done about stigma? Well, this is a synthesis of work done by Anne Stangl and colleagues, where they did a systematic review of studies evaluating stigma interventions, and basically showed that about 90% of these interventions were able to reduce stigma, and most of these interventions have used sort of one or two approaches, but the current evidence is strongest for interventions that are targeted at students, healthcare workers, and community members, and interventions that use both a structural and a counselling-based approach. So we can intervene on stigma. A further example, it was raised earlier today, what are we doing about alcohol? And what we knew in Strive was that in fact WHO and the World Economic Forum already make recommendations about interventions that can be delivered at a structural level to really address problematic alcohol use. So pricing policies that would basically reduce consumption or access to consumption from younger persons by changing the price of alcoholic beverages, comprehensive restrictions and bans on alcohol marketing, and also restrictions on the production, sale, and access or availability of alcohol. And with a particular focus on thinking also about access by younger populations, so that we can sort of defer potentially their access to alcohol and problematic drinking. So in Strive, that evidence had already been generated, but the important work that Strive did was really to work much more at a community level, and through a series of research activities that were both participatory, involving young people, they were able in Tanzania to show the important contribution of alcohol packaged in sachets for that was being used as a kind of entry alcohol by young people. And as a result of this, in 2017, the Tanzanian government issued a ban on the import, manufacturing, sale, and consumption of these alcohol sachets. So again, work where Strive translated kind of evidence that exists and demonstrated that changes can be made to some of these structural factors. So there's another thought that I want to just leave you with about how we can potentially influence the structural barriers to HIV prevention. And this is based on work done by a systematic review of reviews by Shari Krishnaratne and James Hargreaves and others, really to think about what evidence we have for HIV interventions that are either going to reduce incidence or prevalence or uptake of testing or condom use, and try to map them onto this prevention cascade, which really thinks about a population at risk, those who would be motivated to use a method, those who access it, and those who need support for sustained use, and really to see what evidence there is about interventions that could address the motivation, access, or effective use parts of the cascade. So the review of reviews identified 88 reviews that included 292 studies, and overall the sort of key message is that the evidence for interventions to promote demand or effective use of prevention products is less clear, and the strategies, with some strategies being effective and others showing no effect. And clearly more work is really needed to begin to think about how to better drive demand for HIV prevention. But interestingly, there was evidence that suggested that interventions that support access to prevention, so for example, mass condom distribution, mass needle syringe programs, or STI interventions, where those interventions are scaled up, there was evidence to support reductions in HIV incidence with some of those measures. So the take-home message is that scaling up access itself is a structural intervention. Often it involves changes to policies, legislative changes within country, but scaling up access can overcome social barriers to HIV prevention and could potentially be helpful when leading to population-level reductions in incidence. So how do we put this all together? And now is the tricky part of the talk, because I'm hoping that the infographic that Strive has developed will play for you and work. But this is work that now takes those two ideas together and says how we think this thinking around structural factors and the cascade can be brought together.
From research and action since the early 1980s, we've come to understand a lot about HIV, how it is transmitted, what puts people at risk, and some steps that work to prevent transmission. However, some groups and places continue to face high risk of HIV infection, so better prevention programs are urgently needed. A new framework called the HIV Prevention Cascade enables us to use everything we know about HIV to help us tackle the virus. We've tended to group HIV risk and interventions in three categories: biomedical, behavioral, and structural. This way of thinking has been helpful, but it does have problems. We may put all our faith in a biomedical technology, such as pre-exposure prophylaxis or PrEP, without recognizing that we need to support PrEP use. Or We may be over-optimistic about the impact on HIV of improving gender equality if it is not integrated with other preventive steps. In fact, we need to integrate biomedical, behavioral, and structural responses to HIV. And the prevention cascade helps us to do this. Let's consider an example: a priority population facing high risk of HIV infection, adolescent girls and young women in sub-Saharan Africa. In principle, a young woman can choose from and combine a number of direct mechanisms of HIV prevention to protect herself against HIV infection. She could use condoms consistently, or take PrEP every day, or decide not to be sexually active. Different options might suit her at different times in her life, but her choices are likely to be constrained. Let's look at one possible prevention option. A significant number of sexually active young women are not using condoms or not using them reliably. They would benefit from taking PrEP to protect themselves. What is needed to achieve high levels of effective use of PrEP among this group? Out of the total, only a certain number will be motivated to use PrEP as a prevention mechanism. Why is that? A young woman may not know about PrEP, or may not understand her own risk of HIV, or may be constrained by social norms that inhibit women's sexual activity and agency. To increase the number of young women motivated to use PrEP, we need to design new programs or add new and effective elements into existing programs, for instance, in sexual and reproductive health. These elements might include peer-led or clinic-based information and awareness programs, or interventions to shift social norms around PrEP use. Schools, media, integrated health services, and the community could deliver these interventions, and policies will be needed to support high coverage, intensity, and quality of the interventions. Next, we ask, who lacks access to PrEP? Some young women who are motivated to use PrEP may not be able to access it because PrEP is not available, or not easily accessible, or not affordable, or because there's stigma present in the places where PrEP can be accessed. To close the access gap, we could intervene to ensure that health services where PrEP is accessed are convenient, free, and youth-friendly. We could deliver these interventions across the range of places where PrEP might be accessed. To support these interventions, policies would need to establish budgets to provide, for example, antiretrovirals, support, health worker training, and social welfare. Finally, some young women in this population may be motivated to take PrEP and have access to PrEP, but still not be able to take PrEP consistently and effectively over time. Daily adherence may be difficult for a young woman because, for example, her parents or a partner may not approve, or her living situation may be insecure, or her partner may be violent and or abusing alcohol, or stigma around HIV medication may discourage her. How could we strengthen young women's capacity to adhere over time? Programs could include long-term counseling services, economic or gender-based empowerment, and social protection. The health, development, and welfare sectors, such as the government and the NGOs, offer potential platforms with policies needed to ensure such interventions are in place. In this way, the prevention cascade offers a framework for identifying gaps in HIV prevention and for planning interventions to close those gaps. We can then draw on our interdisciplinary understandings of HIV risk, in our example, to focus on support for young women's capacity to adhere to PrEP. We can use the prevention cascade to design interventions for other priority populations, including, for example, sex workers, prisoners, transgender people, and men who have sex with men. We can focus on one or more other direct mechanisms of prevention, for example, male or female condoms and medical male circumcision. We can then identify the most effective interventions and platforms in order to achieve prevention at scale for those facing a high risk of HIV infection. In this way, the HIV prevention cascade can support efforts to reach ambitious global targets for the reduction of new HIV infections.
it worked. I'm very relieved. But hopefully that brings some of the strands of thought together about how we're beginning to think as Strive about scaling up prevention and working our responses to structural factors into programming. So the third lesson, or perhaps it's a message at this point, is that really we need innovative approaches that are going to respond to these structural barriers to HIV prevention. And what I want to do is give you two examples that have been undertaken by Strive investigators. The first is a study that is aimed at thinking about the relationship between treatment as prevention and stigma. And you may know that there have been several population-based or community-based trials that are being undertaken that have aimed to ask this question: if we can achieve the 1990 targets, can we potentially see reductions in HIV incidence at a population level? And some of the challenges to that have been, or the discussions about that have been, that universal test and treat could change the levels of HIV-related stigma if we basically scale up, as we saw in that review of reviews, supply of treatment and testing. Can we potentially overcome stigma? Or will we find that despite our best efforts to scale up universal test and treat, we see that HIV-related stigma, particularly amongst marginalized groups, undermines the effectiveness of our attempts? Or will we see, as a result of these large scale-up programs, that the form of HIV-related stigma changes and that we will then need different responses? So work has been undertaken by colleagues within Strive as part of one of these large UTT trials, the POPART trial. And here is some baseline data from that trial which has been conducted in South Africa and Zambia. And the key message here is that in about a third of these communities, we see people experiencing stigma in one form or another within both of these countries. So what does that mean? Well, the trial will be producing results next year, but there are already some early insights that we have from some of the work that's been done by the team. And the important thing about the work that's been done on stigma by the Strive team is that they've taken a parallel approach, which means that questions have been addressed not just to people living with HIV, but the same question has also been framed for people in the community, vulnerable populations, and health workers. So when asking people who live with HIV, do people talk about you badly? When addressing this to the community, the question is, do people talk badly about people living with HIV? And when the question is addressed to health workers, is, do health workers talk badly about people living with HIV? And this will generate information about stigma from a range of perspectives, which will be important for understanding how stigma changes. So there are three key insights that have emerged from the work to date. The first is that stigma exists in the health facility, and it's not just in the way that people talk, it's in the way that services are organized. And some of you will be completely familiar with this, but kind of where even the way that files are labeled or where people sit can potentially identify them and kind of entrench stigma. This work has also particularly highlighted challenges for community health workers living with HIV, and how highlighted kind of this is a kind of neglected area for attention when it comes to healthcare workers living with HIV. The second insight is really around stigma in the community, and that for some populations, this work really echoes work that's also been done in Zimbabwe with female sex workers, where for some people, the real stigma is being associated with a key population or a marginalized group. And so this is where we can begin to get insights that perhaps the form of stigma is going to change, and that it may not be HIV-related stigma so much as the stigmatized nature of the group to which that person belongs. And the third insight is really around stigma and the uptake of testing and treatment, which is obviously what we're very concerned about, and how stigma may in fact influence then interventions like home-based testing or early linkage to heart, but also how scaling up activities may in fact address some of those barriers. So those are early lessons, and more work from the team will be presented at IAS this week. The second example really is a combination HIV prevention intervention for adolescent girls and young women. And this is based on the observation that highest rates of new HIV infection are in adolescent girls and young women. And that PrEP is a novel intervention that is being introduced into the health system. And there are a number of questions about how to do delivery and how to design services. In addition, we know that gender-based violence is very high in these settings, and the health system has been very slow to respond to gender-based violence, although gender-based violence is associated with many negative health outcomes. So this study really aimed to ask the question, how can we layer on a number of gender-based violence interventions into an HIV program with the idea that we might be able to mitigate some of the negative impacts of violence and harmful norms on testing and PrEP uptake and use. So in Empower, young women are offered testing, they are then offered PrEP if they're HIV negative, they're initiated on PrEP and they are continued on PrEP, and this is offered as part of a comprehensive sexual and reproductive health service. What we did was to add in gender-based violence screening integrated into HIV testing as part of an HIV risk assessment. We convened community dialogues based really on the lessons from SASA around encouraging people to talk about what they consider to be healthy relationships, positive relationships. This also gave us an idea about the importance of creating demand for these new prevention technologies. And then to support PrEP continuation, we designed adherence clubs that had an empowerment curriculum. And the results of Empower will be presented during the course of the conference, so this is a plug for you in those sessions. So I hope, just to kind of conclude it all, I hope that you can see that Strive over the last 7 years has spent a significant amount of time thinking and generating the evidence to really answer the question around how structural factors act as barriers to ART-based prevention through their work both in kind of determining risk, but also in fact acting as practical barriers to access to prevention services. And that it is possible and within meaningful programmatic timeframes to address these barriers. And really what we need now is to begin to combine them into interventions. So putting it all together, as Strive, we believe that biomedical interventions are not going to achieve the ambitious targets to end AIDS on their own without addressing these structural factors that shape HIV and undermine uptake and effective use of prevention. That it's possible that they can be addressed within programmatic timeframes, and now is the time really to think about how to creatively integrate these evidence-based interventions and take them to scale in a way that can begin to achieve these population-level benefits for reducing HIV incidence. This clearly was not the work of one person, and I just really kind of want to make that point again, that there are a number of people really involved in this thinking, and they're not, some of them are in the room, and some of them are not, but really this has been a wonderful 7 years of thinking about how to improve HIV prevention programming. Thanks.
Great, thanks.